So, good evening to everyone. Uh, we have studied till the last lecture related to the azole antifungals, and we have studied them in detail as it is one of the important point in exam point of view. And the next category of drugs that we are going to study are the echinocandins. So echinocandins, the mechanism of action wise, they interfere with the synthesis of the fungal cell wall by inhibiting the synthesis of beta 1,3 D-glucan. Okay, so this beta 1,3 D-glucan, as you can remember from the video which I have shown to you related to the fungal cell membrane and the cell wall, it is one of the cross-linking linkage that connects the cell membrane to the cell wall. Okay, so one being the beta 1,3 and another is beta 1,6. Okay, so out of these two cross linkages, the beta 1,3 D-glucan linkage, its inhibition, its synthesis inhibition, it is done by the echinocandins, the category of drugs. And as this particular linkage doesn't get formed, it leads to the lysis and the cell death. Okay, so we have the three main drugs into it, that is caspofungin, micafungin, and anidulafungin. Okay, and these three drugs, they are available for the intravenous administration. We have to take it once daily. So the micafungin, it is only echinocandin that does not require a loading dose. The other two, that is caspofungin and anidulafungin, they require a loading dose. So the echinocandins, they have potent activity against aspergillus and most candida species, which include those species which are resistant to the azoles. However, they have minimal activity against other fungi. The most common adverse effects related to echinocandins include the fever, rash, nausea, and phlebitis at the infusion site. Phlebitis, it is inflammation of the vessel. Okay, so they should be administered via slow IV infusion, as they can cause a histamine-like reaction, that is flushing, when infused rapidly. Okay, so first drug in that, it is caspofungin. It is a first line option for patient with invasive candidiasis, which includes candidemia, and second line option for invasive aspergillosis in patient who have failed or cannot tolerate amphotericin B or an azole. Okay, so the dose of caspofungin, it should be adjusted with moderate hepatic dysfunction. Okay, so the metabolism of it, as it takes place in liver, that's why if we have to adjust the dose if there is moderate hepatic dysfunction. The concomitant administration of caspofungin with CYP450 enzyme inducer, example of the inducer is the rifampin, which is an anti-tubercular agent. They may require an increase in caspofungin dose. Okay, why there is increase in a requirement of caspofungin dose? Because if there is an inducer which is to be administered with this drug, then it will increase the rate of metabolism of the caspofungin. So if metabolism rate increases, then it will lead to the increase in the elimination of the caspofungin. So if we want to produce the therapeutic effect, then we have to increase the dose. Okay, so the caspofungin should not be co-administered with the cyclosporin due to high incidence of elevated hepatic transaminases with concurrent use. Okay, so cyclosporin, which is an immunosuppressant drug, if administered with the caspofungin, will cause increase in the hepatic transaminase levels. Okay, So next drug, that is mecafungin and anidulafungin. So these drugs, they are the first line options for the treatment of invasive candidiasis, which includes the candidemia. That is presence of candida fungi in the blood. Okay, so the mecafungin also indicated for prophylaxis of invasive candida infections in patients who are undergoing hematopoietic stem cell transplantation. Okay, so these agents, they are not substrate for the CYP450 enzyme, and they do not have any associated drug interactions. So next category of drugs that we are going to see, that is drugs for the cutaneous mycotic infections. Okay, so the first we have seen, that is subcutaneous and the systemic mycotic infections, and now we are talking about drugs which are used in treatment of cutaneous mycotic infection. So there are many drugs, they come under this particular category, but we will be talking about only few drugs, because the azoles, they are also used in treatment of cutaneous mycotic infection. But as we have seen the pharmacology of azoles under subcutaneous and systemic mycotic infection, we won't be talking about them in this particular section. Okay, so mold-like fungi which causes cutaneous infection, they are called as dermatophytes or the tinea. Okay, so the tinea infection, they are classified by the affected site, that is tinea pedis, which refers to the infection of the feet. Okay, so the common dermatomycosis such as tinea infection that appear as rings or round red patches with clear center, they are often referred to as ringworm. So the ringworm infections, they are basically the fungal infections. So this is a misnomer because fungi rather than worms cause the disease. Okay. So the three different fungi that cause majority of cutaneous infection are the trichophyton, then microsporum and epidermophyton. So the first drug that can be used in treatment of the cutaneous mycosis, they are the squalene epoxidase inhibitors. Okay, so these agents, they act by inhibiting an enzyme, that is squalene epoxidase, and thereby it blocks the biosynthesis of ergosterol, which is an essential component of fungal cell membrane. So we have seen one another category of drugs that also inhibits biosynthesis of ergosterol. We have this another enzyme that also helps in the biosynthesis of ergosterol, and the name of enzyme is squalene epoxidase. So the accumulation of the toxic amounts of the squalene, it results in increased membrane permeability, and thus it leads to the death of the cell, fungal cell. Okay, so you can see the enzyme is squalene epoxidase, and it is inhibited by the drugs like, that is butanafin, then nactifin, then terbinafine. Okay, so when this squalene epoxidase is inhibited, it leads to the accumulation of squalene, and this which are nothing but the toxic products, and this toxic product accumulation leads to the fungal cell death. Okay, so next is the first drug in that, it is terbinafine. So the oral terbinafine is the drug of choice for treating the dermatophyte on onychomycosis, okay, which is nothing but fungal infections of the nails. So it is better tolerated, it requires shorter duration of therapy, and is more effective than either itraconazole or griseofulvin for the trichophyton. So the therapy is prolonged, usually about 3 months, but considerably shorter than that with the griseofulvin. The oral terbinafine may also be used for the tinea capitis, which is an infection of the skull. Okay, So topical terbinafine, which is 1% cream preparation or the gel preparation or the solution, it is used to treat the tinea pedis, which is in a tinea infection of the feet. Then tinea corporis, which is a ringworm infestation. Then tinea cruris, sorry, tinea cruris, which is infection of the groin. And tinea versicolor, which happens due to the malassezia furfur. Okay, furfur or furfur. Okay, so duration of treatment is usually 1 week. So antifungal spectrum of terbinafine, it includes it is active against trichophyton. It may also be effective against Candida infection, epidermophyton, and scopulariopsis. But the efficacy in treating the clinical infections due to these pathogens, it has not been established. So primarily it is used for treatment of the trichophyton infections. So pharmacokinetics, it is available for oral and topical administration. The absorption, the bioavailability after oral administration is only 40% due to first pass metabolism. Distribution, it is highly protein bound and it is deposited in skin, nails and in adipose tissues. So the prolonged terminal half-life of 200 to 400 hours may reflect slow release from these particular tissues. So see, the half-life is very long. The metabolism extensively metabolized by several CYP450 isoenzymes and is excreted mainly via the urine. So the drug should be avoided in patients with moderate to severe renal impairment or hepatic dysfunction. So next drug is griseofulvin, and as you can see from the diagram itself, this griseofulvin, it affects the mitosis. Okay, so this causes disruption of the mitotic spindle and thus inhibition of the fungal mitosis. So it has been largely replaced by the oral terbinafine for the treatment of the onychomycosis. Onychomycosis, as we have seen, it is infection of nails. Although it is still used for the dermatophytosis of the scalp and hair. The griseofulvin, it is fungistatic because it inhibits the multiplication process of the fungi. It doesn't cause the fungal cell death, and it requires long duration of treatment. For example, 6 to 12 months for the onychomycosis. In case of terbinafine, it is only 3 months. The drug concentrates in skin, hair, nails and the adipose tissue. So similar as that of the terbinafine. The griseofulvin induces the hepatic CYP450 activity, which increases the rate of metabolism of a number of drugs, which includes the anticoagulants. The use of griseofulvin, it is contraindicated in pregnancy and in patients with the porphyria. So next drug is cyclopyrox. So this cyclopyrox, it is a pyrimidine antimycotic and it inhibits transport of essential elements in the fungal cell and thus disrupting the synthesis of DNA, RNA and the proteins. So this drug is active against trichophyton, epidermophyton, microsporum, Candida and Malassezia. Okay, so cyclopyrox shampoo is used for treatment of seborrheic dermatitis. The tinea pedis, tinea corporis, tinea cruris, then cutaneous candidiasis and tinea versicolor, it may be treated with cream, gel or suspension of the cyclopyrox. The onychomycosis, it can be treated with nail lacquer formulation. You can see this formulation, it is something different from the formulations which we have. Okay, So a novel formulation can be seen of the cyclopyrox for the treatment of the onychomycosis. Sorry. Then we have next drug, that is Tabarol. This drug, it inhibits amino acid transfer, ribonucleic acid synthesis, and thus it prevents fungal protein synthesis. Okay, so this drug, it is active against Trichophyton rubrum, then Trichophyton mentagrophytes, then Candida albicans. Okay, so this becomes its spectrum of activity. A topical solution is approved for topical treatment of toenail onychomycosis, which requires 48 weeks of the treatment. Okay, so around 4 months of treatment is required for the onychomycosis treatment. Okay, then we have next drug, that is tolnaftate. It is topical thiocarbamate, and it distorts the hyphae. It stunts the mycelial growth in susceptible fungi. It is active against epidermophyton, microsporum, and Malassezia furfur. Then tolnaftate, it is used to treat tinea pedis, tinea cruris, and tinea corporis. It is available as solution, cream, and powder. Then we have benzoic acid, which is like ancient preparation, we can say. Okay, so it can be used for the topical antifungal therapy, and when it is combined with the salicylic acid in the ratio of 2 is to 1, that is 2 parts of the benzoic acid and 1 part of salicylic acid, it is called as Whitfield's ointment. Very common one, very ancient preparation. Okay, so this combination, it associate fungistatic activity of benzoic acid with keratolytic activity of salicylic acid, which causes infected stratum corneum to shed. Okay, so it causes a stratum corneum to be removed because of the keratolytic activity and fungistatic activity of benzoic acid. It is used for treating tinea pedis, tinea capitis. A prolonged treatment is required to get the desired results. It causes mild irritation upon application. Okay, so that was the end of my presentation, and with this we have finished with the chapter, that is antifungal agents.